Muchísimas gracias a todos los que están conectados. Voy a hablar un poco en español, porque en verdad el doctor Julio García-Aguilar, que iba a estar con nosotros acá, está en el quirófano y en su reemplazo tenemos al doctor Aron Bercz, que es un fellow que trabaja junto con el doctor Julio García-Aguilar y estuvo envuelto en el proyecto, en el trabajo, lo conoce y entonces nos va a hacer el favor también de presentarlo. Vamos a ver si el doctor Julio consigue un poquito de tiempo y se puede conectar, si termina a tiempo, al menos para la parte de los comentarios y las preguntas. Em, Esta vez la presentación, por esta excepción, va a ser en inglés, pero todas las preguntas, los comentarios y demás se pueden hacer en español y vamos a hacer una traducción para Aron, para que pueda entender las preguntas. Después, otra cosa importante es que por debajo, en el Zoom, van a tener el botón que dice más o more, depende de cómo lo tengan, que pueden usar la transcripción para español. Entonces, toda la presentación de Aaron la pueden traducir al español y aunque no sea exacto, exacto, se entiende bastante. Así que eso solo en verdad para esta sesión un poco particular, que lo vamos a hacer en inglés, pero en un Span-English. Vamos a intentar mixturar. Aaron tiene que practicar su español un poquito y vamos entre todos haciendo que todos podamos hacer preguntas y comentarios sobre este trabajo. Entonces ya tenemos gente saludando, conectados desde España. Tenemos mucha gente también de Latinoamérica, así que bienvenidos a todos. Y creo que en 1 o 2 minutos más ya vamos a comenzar con la presentación y damos tiempo después a comentarios y preguntas. Hello, Josh.
Hi, Laura. I'm joining Julio's in the OR, so I'm going to join and help discuss the paper.
Perfect. Thank you so much for connecting here.
Of course, of course. How are you?
Oh,
Good to see you.
good to see you. I was explaining to Aaron that we will do a mix between Spanish and English
Great.
because, of course, that if they wanted to ask in Spanish, I will translate. If they wanted to ask in English, it's okay.
Sure.
But the idea of this year was to have the opportunity to ask in Spanish, to talk, to comment. So we will do a mix. Okay?
Sounds great. Sounds great. Wonderful. Okay,
Good.
great.
Entonces, I think that we can start. Vamos a comenzar y le voy a dar la palabra y la presentación a Aaron, que va a comenzar con la presentación del trabajo. Thank you, Aaron.
All right. Good evening, everyone in Europe and internationally. My name is Aaron Bercz. I am a research fellow in Dr. Smith's lab. I was one of the contributors to this paper that I'll be discussing. But Dr. Smith, Dr. Garcia-Aguilar, and I are really grateful for this invitation to discuss our recent work, which correlates to clinical outcomes to oncologic outcomes in the context of watch and wait for our off-protocol patients. So Dr. Smith will be joining us right now while Dr. Garcia-Aguilar is in the operating room, and then we'll try to have a discussion afterwards in Spanish and English, but I'm not sure if my 5 years of high school Spanish will suffice for a high-level discussion in Spanish. So here are our disclosures. Briefly, this slide gives an overview of the modern treatment paradigm for locally advanced rectal cancer. Patients typically receive neoadjuvant therapy in the form of total neoadjuvant therapy or immunotherapy in modern times. And this is followed by a clinical assessment of treatment response, generally in 7 to 8 weeks. Broadly speaking, patients who achieve a clinical complete response are eligible for watch and wait, while patients who achieve an incomplete response are advised to undergo total mesorectal excision. Importantly, the Omer trial demonstrated that rectal preservation is safe for well-selected patients with comparable disease-free survival and overall survival compared to upfront surgery. Moreover, 5-year organ preservation can be achieved in approximately half of all patients. However, a quarter of patients who continue on watch and wait management can be expected to develop a local regrowth, which typically occurs within 2 years of completing treatment. However, the management of patients who achieve a strong but not quite complete response, known as a near complete response, remains a topic of debate. Briefly, clinical response to neoadjuvant therapy is classified according to endoscopy, physical exam, and MRI. A clinical complete response, or CCR, is defined as a flat white scar on endoscopy with a normal digital rectal exam and no sign of tumor on T2-weighted or DWI MRI. A near complete response is defined typically as a shallow ulcer or a slight nodularity on endoscopy with some induration palpable on rectal exam and slight restricted diffusion on T2-weighted imaging. And then an incomplete response, of course, involves obvious tumor on any of these 3 modalities. There is prospective evidence supporting the notion that treatment response is associated with oncologic outcomes. The German rectal cancer trial stratified results from previous trials by pathologic tumor regression grade, which revealed an association between poor pathologic response to neoadjuvant therapy to worse oncologic outcomes. Similarly, analysis from the Omer trial, according to clinical response to total neoadjuvant therapy, yielded higher rates of local regrowth and worse disease-free survival among near complete response patients compared to clinical complete response patients. Furthermore, a pooled analysis from the Omer and the German AIO-12 trial demonstrated that disease-free survival was similar across paired pathologic and clinical response grades, showing an overall correlation with the degree of response. However, the International Watch and Wait Database Consortium has suggested equivalent organ preservation and distant metastasis-free survival and overall survival between patients who have a clinical complete response and a near complete response. And this is graphically demonstrated by this organ preservation curve, which essentially shows equivalent 5-year organ preservation rates between those patients who have an initial CCR and a delayed CCR. So while organ preservation has become a standard option for patients who achieve a clinical complete response, the safety and the optimal approach in the context of a near complete response remains a point of controversy. Additionally, we aim to validate the prospective findings seen in the Omer trial and the German trial using a cohort of patients treated outside of the clinical setting. So these are all off-protocol patients. So Dr. Roni Rosen's work was a single center retrospective cohort study, which involved off-protocol patients with stage 1 through 3 disease that were treated here at Memorial Sloan Kettering over a 14-year time span. The patients were categorized into 3 cohorts, either a CCR, NCR, or an ICR. Patients who achieved a CCR and opted for non-operative management underwent rigorous surveillance through watch and wait. And local regrowth was defined as any sign of tumor in the rectum, on digital rectal exam, on endoscopy, or imaging. If a local regrowth was identified, that was an indication for a salvage TME. For patients who were deemed to be a near complete response, this was documented as such in the note of the attending surgeon. And in general, these patients had findings such as small areas of ulceration, nodularity, or erythema, as described by the Memorial Sloan Kettering regression schema, or had minimal residual disease on MRI. However, this label of an NCR was ultimately at the discretion of the treating surgeon. And then we used Kaplan-Meier methods to estimate the cumulative local regrowth rate, the organ preservation rate, disease-free survival, and overall survival. We identified over 1,400 patients with biopsy-proven rectal adenocarcinoma who underwent treatment at Memorial Sloan Kettering. Patients were excluded if they had stage 4 disease, progression of disease or death during treatment, had a prior transanal excision, had synchronous cancers, or were missing important treatment dates or were lost to follow-up. After excluding these patients, we were left with 1,230 patients who were divided into 3 cohorts according to their clinical response. 646 patients with an incomplete response, 189 patients with a near complete response, and 395 patients with a clinical complete response. This was a gender-balanced cohort with the majority of patients having locally advanced disease, and they received a total neoadjuvant approach. The median follow-up for each of these cohorts exceeded 4 years from the completion of neoadjuvant therapy. And here's a broad overview of the 3 cohorts of interest. Within the CCR group, 351 patients, or about 90%, entered watch and wait, whereas 44 patients elected to pursue the recommended standard of care at that time, which was surgery. Of the 351 watch and wait patients, local regrowth occurred in 27%. 2/3 of the patients who underwent upfront surgery for a CCR demonstrated a pathologic complete response after surgery. The near complete response cohort consisted of 189 patients, of whom surgery was recommended in 108 because they did not evolve into a CCR. However, the PCR rate was much lower compared to that in the CCR group at 20% compared to 66%. Of the 81 patients who continued with watch and wait, 41% developed a local regrowth. For CCR patients, the estimated 5-year local regrowth rate was 24%, with a median time to local regrowth of about 11 months. For the near complete response patients, the estimated 5-year local regrowth rate was 40%. This corresponded to a 5-year organ preservation rate of 73% in the complete responders and a 5-year organ preservation rate of 53% in the near complete responders. Notably, local regrowth was also associated with an increased rate of distant metastases in the CCR cohort, with 27% of patients with regrowth having distant metastases compared to 7% without local regrowth. This was also seen in the NCR cohort, as local regrowth is associated with a higher rate of distant metastases at 48% with regrowth versus 17% without regrowth. The 5-year disease-free survival increased with greater clinical response to neoadjuvant therapy, with intermediate outcomes noted for patients with near complete responses at 73%, compared to CCR patients or ICR patients. Overall survival at 5 years was similar between all 3 cohorts, at 90% for CCR, 86% for NCR, and 85% for ICR. When assessing the time it took to achieve a clinical complete response, in the CCR cohort, determination of a complete response was made at a median of 7 weeks after finishing neoadjuvant therapy. In the near NCR cohort, conversion to a CCR was made at a median of 19 weeks after finishing neoadjuvant therapy. When assessing the time it took for an NCR to evolve to a CCR, patients who did not achieve a complete response within 24 weeks of neoadjuvant therapy were less likely to achieve organ preservation, as 68% of patients who made that conversion by 24 weeks achieved organ preservation, compared to 24% who did not make that conversion, with an odds ratio of 6.7. To summarize, near complete response patients entering watch and wait have an associated higher risk of local regrowth compared to their CCR counterparts. NCR patients were demonstrated to have an intermediate disease-free survival compared to CCR and ICR patients, but the overall survival was similar between the 3 cohorts. We show that local regrowths are associated with an increased risk of distant metastases. And we also see that near complete response patients who do not make the conversion to a clinical complete response within 24 weeks of completing therapy are less likely to achieve organ preservation. Although this represents a large cohort of CCR and NCR patients, which enable a long-term assessment of treatment response and recurrence patterns, the retrospective analysis is a notable limitation of the study. Because of the prolonged period, earlier patients who may have had a near complete response may have been treated more likely as an incomplete response and therefore underwent surgery without the option for watch and wait, as the NCR classification really only became widely utilized around 2014. So this really limits any direct statistical comparison between the three groups. And it's also worth noting that during this 14-year time span, treatment paradigms did change as total therapy has now become standard of care. And at the start of this, when patients were first treated in the study, watch and wait was not quite as established as it was at the end of the study. I'd like to thank everyone that made this work possible, and this truly could not have been done without a collaborative effort. I'd be happy to take any questions and happy to initiate the discussion.
Thank you so much, Aron, to present. Great presentation. So, entonces, ya tenemos muchas personas conectadas en el chat, gente de Perú, de Colombia, de Argentina, de España. Muchísimas gracias por estar conectados. First of all, I will ask Dr. Schmidt if you want to do any comment or about the presentation, or we can go for the question. We have already one hand, Rodrigo Perez.
Sure. Yeah. First, I'll just. Can you hear me? Okay.
Yes, perfectly.
Yeah. First, thanks to Aron for presenting this work. I think it's important to show that there's similar response and oncologic outcomes seen outside of the recent trial data off protocol, which I think is important and suggests that the biology is still the strongest predictor of complete response, near complete response, incomplete response. And I think the other thing that we learned from this that was very interesting is that if you didn't evolve to a complete response, you saw that the data was pretty strong at 24, essentially by 6 months. If that NCR hadn't evolved to a CCR, it's not going to. And so I think it's important clinically, clinical information there, because we do many centers, including our own. We'd ideally love to manage patients on a watch and wait trial protocol if at all possible. But of course, many patients come to us for watch and wait recommendations off protocol. And so I think the data are important in terms of how we counsel patients and how we consider those responses that are not quite perfect, because you could see the CCRs snap into place pretty quickly within that 7 to 8 week period. It does take a little bit longer for the NCRs to evolve, but I think there's a time frame that those, if they don't get there, then we need to have a realistic conversation with the patient about TME. So thanks again for the opportunity and look forward to the discussion.
Thanks to you. So I will start with the questions. Yeah, okay. Now Rodrigo is there. Rodrigo, you want to, in Spanish or in English?
Professor, welcome.
Hi, Aron. Hi, Josh, and thanks for sharing the data. This is a very controversial topic in organ preservation strategy, and I really appreciate you guys sharing the data, and this is a lot of patients. So, Aron, maybe if it's possible, if you can show us the slide of the overview of the treatment of patients. If I understood correctly, patients with a near complete response were managed either TME or watch and wait. Those who underwent watch and wait, just another one, go ahead. That's the one. Thanks. So my question is, the patients who underwent, so let's talk about the middle section, okay? Forget about the incomplete responses and forget about the complete responses. It looks like that the complete responses are very much replicating our experience in the international watch and wait database, meaning that 30% local regrowth, and of those, apparently 29% distant metastasis rate, which is very, very, very close to what we found. My concern is near complete responses. Now, my question is, of those who underwent watch and wait for a near complete response, there was a 41% local regrowth. And of the 41, if I understood correctly, 47% had distant metastasis, correct?
Yeah, so that 47% is of the patients who had, of local regrowth, 41% had distant metastases.
Okay. So my question would be, and perhaps you can comment, you and Josh, to me, the perfect comparator group for that particular group of patients would have been the near complete responses in that same middle section who underwent TME and did not have a PCR, meaning the 80% of the 108 patients. Do we have the distant metastasis rate among the ones who underwent TME for a near complete response to compare with the ones who underwent watch and wait? Does my question make sense to you?
Yes. So actually, we did look at that in this paper. So we compared disease-free survival and overall survival between those NCR patients who continue to watch and wait and the NCR patients who went to the surgery. So we did see that there was improved DFS and overall survival in the patients with an NCR that went to surgery as opposed to watch and wait. However, something that is a confounder, as you mentioned, is the proportion of patients who ultimately have a pathologically response. So 20% of those patients that went to surgery for an NCR had no residual tumor. Right. So that will influence the DFS and the overall survival comparisons. But that is one of the limitations of this retrospective analysis. So I understand that there might be different comparators that we like to consider, but I think for the purposes of this paper, we thought that comparing the NCR patients that went to surgery versus watch and wait would be maybe the most digestible for the readers.
Okay, so
it's a great point. It's a great point,
yeah.
Rodrigo, and I think the best your the comparison you propose would be ideal. I think one of the limitations, as Aaron mentioned, is that the NCR here was determined by the surgeon versus in the prospective data. And I think you probably ran into this as well when you looked in the International Watch and Wait database. Whether it was a late CCR or immediate CCR, that's still a determination by the surgeon or the clinician at the time of the decision-making process. And so that certainly is a limitation in that, also in that analysis, which provides some heterogeneity there that still makes that comparison, even as the one you proposed, a little bit tricky. But I think, as Aaron just mentioned, yes, you could make that comparison, but still the number of past CRs in the TME group versus those, and that because at the end of the day, those that are in that watch and wait group, as you make clear, down the fork in the road there on the right, those were NCRs that converted, right? That were right. NCRs that appeared to be CCRs, but as and everybody else on the call who does watch and wait, those are the the wolf in sheep's clothing. Those are the ones that right. Become those 40% local regrowth. So ideally, you would have said to those patients, "Hey, this is not a true response," and so you would have, liked to have shifted those patients to the other side, and it would be great to have a predictor to say, we would love to have you in this NCR group that's sustained to a CCR, not a false CCR, because there are some NCRs that do become true responses, right? And so this NCR allows patients to have an organ preservation option, but the caveat here is, and I think you're bringing this up, is that when you have an NCR there's some risk there that we have to counsel the patients. And I think the data from your group, from our group, from the the German trial, when you have an intermediate response, the oncologic outcomes are not the same.
So, I'm sorry, Laura is asking me to translate what we discussed, but I still have a question, so I don't want to lose track of my question. So sorry, Laura, I'm just gonna stick on the English.
Yeah, but
Then
just
you
ask
can
in Spanish and in English. Just
Okay, so I'll translate what we just discussed.
Yeah, translate it and we'll go back to it.
Mi pregunta fue, los pacientes que tienen respuesta casi completa y son sometidos a watch and wait, tuvieron, cuando hubo un regrowth, un recrecimiento, un 47% de metástasis de estancia. Yo pregunté a Aron qué pasó con los pacientes con respuestas casi completas que fueron operados de una, y él respondió que los pacientes operados de una fueron mejor desde el punto de vista de disease-free survival que los pacientes que fueron a watch and wait. Y sí, la limitación es que el grupo de watch and wait hubo un casi 40%, 50% de respuestas completas, mientras el grupo que fue operado hubo solamente un 20% de respuestas patológicas completas, y es difícil comparar los dos grupos. I'm going to go back to English very quickly. Because when you have a near complete response, and this is going to be a tricky question for both of you, when you have a near complete response, you don't know whether this is going to transition into a complete response and whether this is going to be a complete pathological response if you do TME. And by looking at the data, it's almost like a 50-50 if you still watch and wait on these patients, that maybe 50% will transition into a complete response and the other 50% will not. And on one hand, if you do TME, you lose the opportunity for organ preservation. But apparently, as Aron just said, you actually have a better outcome in terms of disease-free survival. And I agree that simply because we don't know what's going to happen, it's a risk that you have to take. And the question is, maybe the question to the patient is, are you willing to take the risk of inferior disease-free survival for the sake of a higher chance of organ preservation? Because that's really the point. And maybe we should actually, and this is something we need to, really consider in the setting of a near complete response. Is that, am I being too?
No, I think that states it well. And I think, Aaron's, you probably remember that paper, Rodrigo. Aaron's paper asked that question from, I think it was 2018, the patient perspective. They asked that question exactly, and the patients were in fact willing to take on that risk for organ preservation. So I think we have data, and I think the Germans in their patient preference paper as well, prior to the German trial initiation, have data to support the fact that the patients are willing to take that risk.
And I think the only,
I think they're much more willing to take it than we are, is my perspective. And I think I think it's worth asking as we move forward in this discussion and to populate our experience with what we know now, and to have that conversation as we go forward.
I think, I agree. I think that the problem is watch and wait for a complete response. You're talking about 27, 30% at the most. When you start talking about 50% chances of a distant metastasis rate, the story may change. It depends on how much are you willing to risk in terms of achieving organ preservation. And I fully understand that most patients they don't even listen to this talk. When you tell them what the risk of distant metastasis, They want to know. They do not want to know about it. They simply want to go into watch and wait, and I get that. But this is something we need to be very careful, because it's not the 30% and 50%, as Aron just said, and you confirmed, they're actually different in terms of disease-free survival. If you look at the curves of disease-free survival of near complete responses, they're different from patients with the complete clinical responses.
Yeah. Although the overall survival is nearly identical.
Yeah.
Okay.
Okay, thank you. Aron, can you stop sharing the presentation? Yeah, perfect. Thank you, Rodrigo. So we have now a question from the chat. Jorge San José Gómez está preguntando. So he asked, how many times do you evaluate the patients to decide if they go to watch and wait after TNT? Aron or Smith?
Aron, go ahead.
Yeah.
So obviously, this is a two-way street regarding with what the patient wants and what our professional opinion is based off the evidence that we have based on endoscopy, MRI, and exam. So we know the data, and we are a high volume watch and wait center, so we have the experience to confidently tell a patient whether you are indeed a good candidate or not for watch and wait. So we try to help the patient make the most informed decision possible. But ultimately, every decision for the patient is potentially more consequential than for us. So we really do try to listen to the patient. And if they're very adamant about foregoing surgery, then we're willing to work with them. But we do clearly tell them the risks and benefits of doing so. But ultimately, patient care is definitely a two-way street.
I think what he's getting at. So we look at this. The first evaluation is about 8 weeks post TNT, and then if it's a near complete response, we give them another 8 weeks. In the context of the trial that we're currently undergoing, we don't wait any more than this 20 to 24 week period before we make a decision for surgery. If they have a persistent NCR, we recommend TME. We know
after the
from
second evaluation,
what's that?
Near complete in the
2 evaluations. If it hasn't evolved, we recommend TME. Yeah, so it's essentially no more than that 24-week period. And that's similar in the off-protocol patients. I think we learned from this that if you haven't evolved to a CCR by that 24-week period, that it doesn't seem like it's going to budge.
And of course, sometimes we recommend TME, but the patient doesn't accept.
Some of them don't. We know. It's just we know it from the French data. We know it from our own data, right?
Yeah. La pregunta fue, ¿cuántas veces evalúan a los pacientes con respuesta casi completa antes de decidir si entran en el programa de Watch and Wait o si van a recomendar cirugía? La verdad que la respuesta es, la primera evaluación es a las 7 semanas, 8 semanas después de TNT, del fin de la consolidación. Y si tiene una respuesta casi completa, esperan otras 8 semanas y vuelven a evaluar. Lo que hacen es recomendar eso, entre 8 y 12 semanas, las evaluaciones. Si en la segunda evaluación mantiene una respuesta casi completa y no llegó a los criterios estrictos de respuesta clínica completa, recomiendan TME, cirugía. Claro que hay pacientes que igualmente pueden rechazar y se mantienen un poquito más en vigilancia, pero la recomendación es avanzar para cirugía. We will wait for more questions from the chat or some people that wanted to ask, but I want to do a question for you regarding time to evaluation. So it was interesting because when we evaluate this in the international watch and wait, the time to achieve a complete clinical response was not associated with worse outcomes. But here, you show that the time was a factor for worse outcomes, right? So the question is, do you think that perhaps the difference between the international watch and wait and your court is because the time that we are waiting to decide is shorter in our group? I mean, we evaluate after the end of radiotherapy. So if the patient doesn't achieve a complete clinical response in the first assessment, and it's between 8 and 10 weeks, at the end of radiotherapy, we wait a little longer, another 8 weeks. If they don't achieve, we are a little concerned about continue watching this patient, and we offer some, at least, surgery. But on the others, and we didn't find any difference between this time of achieving a complete response a little longer than the patients with complete clinical response in the first assessment. Do you worry about this, that you are waiting too much? Are you going to, or at least with this result, that you are seeing that waiting longer may increase the chances of local regrowth, increase the chances of metastasis, to include an early stage evaluation, so you have a comparator between the first assessment that you are having now, just to see if the patient actually it's a near because it's responding better or it's worse than in the previous assessment. I don't know if you understand my question.
So do you think you're suggesting that if it's a near complete response, maybe they need an earlier reassessment, and if it hasn't,
To have a comparison.
yeah, compare somebody where you look more frequently
Yes.
versus the usual
Exactly.
8 to 12 weeks.
Just thinking about why
'Cause
you
if you
have a
looked at
different
if you looked
outcomes
at
that
Yeah.
the international watch and wait.
Yeah, I
Do you
think it's
think that it
interesting. I
could be
mean, we have
something?
I guess one potential here with our own data set, we have a very granular data set. I mean, we can look very, down to the patient level, the physician level, versus in the watch and wait database, maybe it's a little harder to get down to some of the fine details. But at the same time, I think, people that had this near complete response were given a little bit more time, in the context of this study, there you have to factor in that there's the patient preference and then the physician patient discussion. And I think that plays a role in these patients who have a near complete response, where there is likely a very strong patient preference to have organ preservation, which played into, let's wait a little bit longer, let's wait a little bit longer. And eventually we know that those tumors just are not going to respond. And what we see, I think, is that those are tumors that have a different biology, and clearly a different biology than the incomplete responders who have worse disease-free survival. There's no real discussion about those patients. There's no organ preservation option in those groups. But you do give those patients with near complete response who then evolve to a complete response that had a decent outcome, the opportunity for organ preservation. So, I don't think it means we just say a near complete responder, we're going to just take straight to the surgery. I think it's reasonable to give them an additional reevaluation. The second reevaluation, I hear what you're saying. Is that a wasted reevaluation? I mean, if it's not going to, I think, is there a rationale to say, if it hasn't evolved after that first reevaluation, is it really going to evolve? I think that's an interesting academic question. I mean, I think we could ask that question. What happened at that second reevaluation? How many of those evolved to a clinical complete response? What's the fall off after that? Because I think that could also help in counseling the patients. And then the short interval, I'm not sure if the short interval would make that much difference, to be honest. It's a very good question, though.
Yeah, maybe you have patients that, I mean, just to comment, even for the audience, the important evaluating the near complete response is, if you want to wait, at least you have to improve. Maybe in the second assessment, it's not a perfect complete clinical response, but has improvement compared with the previous one, right? Yeah.
As Julio taught me that, these tumors, as long as it continues to respond,
Exactly.
there's no need to worry, right?
Exactly.
If it stops responding or it starts going the other way, those are the ones that you need to stop and say, okay, surgery is the right way to go. But if it continues to evolve, then you can be patient. You can continue to watch.
Yeah. So the question was actually that if you have a previous, not to have any decision yet, just using as a comparator, if in the middle or at the end of radiotherapy, then at the end of TNT, you have your second assessment and you already know if it is improving or not, or if it's getting worse.
Yeah.
Because
And for that reason, Laura, we've built in the Janus trial. We have an early look. So we look after radiotherapy and we see what happens, because I'm very interested, because I think that my opinion is that the response actually is early. And I think we learn who's going to be the complete responder versus not very early, because my opinion is that radiotherapy is very powerful and that those who respond are going to have an exquisite response to the radiotherapy pretty early on. So I think it's important to look early. And so after long course radiation in the Janus trial, we're looking before they start chemo to see what the response is there. I think that's going to be instructive to us in the future.
Yeah, me too. Okay, so I have more questions from the chat. Some comments saying that thank you so much for the presentation. And Marco Achurra is asking, I will ask in Spanish just to read the question and then I will translate to you. En un paciente que completó TNT y tiene una respuesta completa y se decide watch and wait. Durante la vigilancia presenta una lesión menor de 15 milímetros en el lugar primario, pero la biopsia es negativa y el estudio de la resonancia no es categórico para regrowth. ¿Prepararías al paciente para ir al quirófano o repetirías la resonancia en 3 meses? So here is a clinical question about a patient. So you have a patient that finished TNT and has a complete clinical response and enter in the watch and wait program. Then during the surveillance, you have a lesion less than 15 millimeters at the level of the scar. Do some biopsies and the biopsies comes negative for tumor, and the MR is not categoric. It's not saying it's a regrowth. They don't know. So would you recommend go to the OR or a new assessment? And if you are recommending a new assessment, when?
Yeah, I mean, sometimes what happens in these scars is, we know this from our own experience and others have described, you can develop polypoid tissue at the scar, not cancer tissue, because polypoid tissue can be radio resistant. And so if the biopsies are negative, if you chose to biopsy, sometimes some of these things that are just polyps could be removed with, sometimes even ESD or other possible options to preserve the rectum. So if you're convinced, for example, if the MRI is negative, the FlexSig is convincing that this is a superficial lesion and the biopsy is not consistent with adenocarcinoma and it looks polypoid, you could potentially have an endoscopic option to continue preserving the rectum. I think with other data that's supportive of a complete response, and this looks to be just resistant polypoid tissue at the scar, I think you could still preserve the rectum using an ESD approach. I don't know, not looking at the endoscopic view here, I'm not sure what the lesion looks like, but that's what I'm envisioning here as a small polypoid lesion at the scar.
Okay, so I will translate. La idea es que con una biopsia negativa en un tejido, una cicatriz que cambió, no hay que quedarse tranquilos por más que la resonancia diga que no es categórica para identificar el regrowth, pero al menos pensar en una resección local, ESD o transmural, para tener la confirmación y darle otra nueva oportunidad de preservación de órgano. Claro que también hay que evaluar el estadio inicial, ¿no? Perfect. I have more questions from the audience. So, doctor Gervasio Salgado, la pregunta es, en español primero, ¿qué aconsejan cuando la respuesta clínica es endoscópica y clínica, pero no en la resonancia? So, he's asking, what do you recommend when you have an endoscopic and clinically complete response, but in the MR is still a not clinical complete response?
Wait,
So, you have,
wait. The endoscopic is the
okay,
is king.
perfect.
Absolutely. Just wait.
Entonces esperamos más, porque la respuesta endoscópica es lo más importante, es la que dirige la decisión clínica, así que se espera un poco más.
The MRI lags behind. Always. It always lags behind.
Tenemos otra pregunta. Eins Ibáñez pregunta, ¿qué factores histológicos y moleculares pueden predecir la respuesta en near complete response?
No,
Entonces, la
not
pregunta
yet.
es, the question is,
I
do you have
wish we don't have it yet.
molecular factors? No. To
Not
predict
yet.
near complete response? No, we don't have.
No, we're working on it, but we don't know yet.
Okay. Ok. Diego Bertani, en la pregunta, cuál es la opinión que tienen sobre la resección local en el escenario de un posible regrowth? So the question is, what do you think about local excisions when you are suspecting a local regrowth?
We didn't recommend it in Oprah, and I don't recommend it in the context of the way that I manage watch and wait patients. It doesn't mean that it's not being done, but we haven't. I don't recommend it. I think TME is the safest way. It's a debate in and of itself. We could have a whole other hour discussion on it, but I recommend TME. If I see a regrowth, I recommend TME.
Okay. Yeah, because the question was regarding the previous clinical case. I mean, if you have a sure that it's a regrowth, or at least a hard
If
suspicion of
it's
a regrowth, TME is the recommendation.
That's right. Yeah,
And
there's a
local
difference
excision
between a
just,
small little polypoid thing at the scar versus a regrowth. The regrowth is something that I see endoscopically or in the mesorectum. That's looks like a cancer coming back into the muscular wall or that I can see or feel. I don't, regrowths are not superficial polypoid lesions. These come back and they're real and you can see them.
and on the other hand, you have to have, of course, that if the patient recused surgery and you are offering organ preservation, that we have patients that doesn't want an APR or a TME. So just to check the baseline stage, right? Before recommending local excision for a regrowth. We have some patients with local
Yeah.
regrowth managed by local excision.
Yeah, it could be. You can do it. There's
The
a price to
recommendation is
pay
TME.
sometimes. Yeah, there's a price to pay. You could burn a bridge in terms of your mesorectal excision in future. There's some issues that can occur there.
Perfecto. Entonces, que quede como el mensaje, si tenemos un recrecimiento local, la recomendación tiene que ser TME, cirugía, resección completa, y claro que va a haber casos en los que resección local puede tener un papel, sobre todo cuando el estadio inicial también era temprano. So, more questions here. Jorge San José Gómez.
Yeah, I see that question. So for the first
Yeah,
2 years,
hey.
we do endoscopy every 3 months, and then we do MRI every 6 months.
Yeah.
And then from years 3 to 5, we do endoscopy every 6 months and MRI. For the third year, we do MRI once a year. And then interestingly, because of the Oprah data, MRI is not really recommended after year 3. So we do MRI as necessary for years 4 and 5, but just do endoscopy every 6 months for years 3, 4, and 5. So MRI relatively frequently, early on, first 2 years, and then annually year 3, and then as needed, necessary 4 and 5. And that's very different in Oprah. There were a lot of MRI, much more frequently, but I think what we learned is that after 2 years, most of the local regrowths occur within 2 years, 99% within 3 years, really not much action at all after 3 years. So based on that, we modified our surveillance schedule some. But we continue with endoscopy for 5 years, as I just mentioned.
You delay only the MR.
Yeah.
And we have another question. What about if it's an adenoma? I think that maybe it's related to the lesion in the scar. Eduardo Pachet, si querés aclarar un poco más la pregunta, si es un adenoma en el nivel de la cicatriz. Let's go for that. If it's an adenoma, a residual adenoma. What do you do with residual adenomas?
I think that's similar to the case that we talked about before. You could also consider ESD in that case.
ESD, perfect. Good. Well, we have 1 hour of discussion. What do you do for surveillance? Jorge San Jose Gómez, otra vez. After 5 years, and how often? Do you maintain
Yeah, it's a good question. We have very rare local regrowth or disease recurrence after year 5. I think we have I think 2 or 3 maybe who had a local regrowth after year 5 at our series, Aaron. Maybe at year 8 there was 1, but in general we tell the patients after year 5 we can stop surveillance and they can go into survivorship. But in my experience, the patients never want to leave. I have patients that when I started here, they're still seeing me. They're at year 8, 9, 10. So in my experience, they never want to leave. So they still come back for their annual endoscopy.
Yeah, at least that one. Annual endoscopy for everyone. Now, we have patients that are more happy to stop after 5, 6 years. But
yeah,
of course,
once a year. Exactly. Yeah, once a year.
Are really
the only
afraid.
patients who don't want to do endoscopy after that are the anal cancer patients don't want to come back, but the rectal cancer patients want to keep coming back.
So once a year then. Yes. Una vez por año, cuando los pacientes no quieren dejar el seguimiento y el protocolo porque están con miedo. Ok. Muchísimas gracias. Thank you very much for your participation and congratulations about the paper and the oral presentation, Aron. And it was an honor to have you here.
Laura, thanks for having us. Good to see you.
Good to see you. And
all the best, and thanks to everybody who joined.
Recomendando a todos que las sesiones están grabadas para el canal de YouTube y pueden ver todas las sesiones grabadas junto con esta en el canal de YouTube. Así que muchísimas gracias a todos los que se conectaron. Espero que lo hayan disfrutado tanto como nosotros y espero verlos en la próxima edición. Thank you.
Thank you very much.
Bye,
Take care.
Aaron.
Bye-bye.